here are the glomerulus. As you can see here, these are the tubules. These are the tubules filled with acute inflammation. Acute inflammation means neutrophils. So tubules are filled with neutrophils along with interstitial involvement of neutrophils also. So if you see acute neutrophils or acute inflammation, any process is called acute pyelonephritis. Higher magnification of the previous picture, again, acute inflammation or acute neutrophils filling the tubules, filling the tubules and in the interstitium. So again, neutrophils, acute pyelonephritis. If these neutrophils involve or goes into the distal tubules, the patient will be presenting with WBC. Gross description of kidney, as you can see, by half into two. Here are the abnormalities. These whitish areas are the abnormal one here. It's called papillary necrosis. If acute pyelonephritis goes untreated, the patient will have a severe complication called papillary necrosis. Papillary necrosis. Most likely to be seen in a patient with diabetes. But even in analgesic nephropathy can be seen the papillary necrosis. But most likely is patient with diabetic having acute pyelonephritis that is not resolving or not having any treatment. So this is as a complication. Another complication could be due to infection. Here we have a PS special stain that will demonstrate for us the organism. And here we have the normal urothelium lining. Here we have a collection of organisms. This organism is called Candida albicans. Candida albicans. Why? Because it's having a pseudohyphae and body and some spores here. So these are all called Candida albicans. The fungal infection is much less common than the bacterial infection, but both can be seen as an ascending infection. What means ascending? It's coming from down of the urinary system, most likely from the urinary bladder. So the infection will go from the urinary bladder up to the kidney. In this picture, what you can see, diffuse infiltration of the interstitium of the kidney by a chronic inflammatory cell. So we say acute means neutrophils, chronic means lymphocytes. So here we have a chronic inflammatory cells infiltration of the interstitium of the kidney. So this is a chronic pyelonephritis. Higher magnification of the previous one, showing the lymphocytes aggregation or lymphocyte infiltration of the interstitium, along with what we have here, a plasma cells. So chronic inflammation like lymphocyte can be seen in other conditions, not only the chronic pyelonephritis. Also you can see it in glomerulonephritis, nephrosclerosis. But the most characteristic feature of chronic pyelonephritis is the presence of plasma cells. Plasma cells should be there to call it a chronic pyelonephritis. Sometimes the long-standing renal infection can mimic neoplasm or a mass-like lesion. So it will be a confusion for the physician himself. This condition is called xanthogranulomatous pyelonephritis. Form a mass-like lesion with necrosis and hemorrhage inside it. So this condition is not a true neoplasm. It's due to a long-standing of renal infection, xanthogranulomatous pyelonephritis. How you can see this condition under the microscope? Because it's xanthogranulomatous, so it's composed mainly of foamy macrophages. All these are foamy macrophages admixed with lymphocytes and some neutrophils. So this will indicate for you what? There is a long-standing or ongoing inflammation of the renal parenchyma. Going into the acute tubular necrosis, or ATM. Acute tubular necrosis, you have two variants or two types of it. One is called ischemic, the other called toxic. So what are the difference between these two? Ischemic acute tubular necrosis means that there is patchy involvement or discontinuous involvement of the tubules. These are the proximal tubules, loop of head, and distal convoluted tubules. So there is patchy involvement of the tubules in case of ischemic acute tubular necrosis. But for toxic acute tubular necrosis, it's continuous or diffused involvement of the tubules. So where we can see ischemic acute tubular necrosis, in case of heart failure, the patient is having heart failure and then accompanied by hypotension. This will precipitate ischemic acute tubular necrosis. But in case of toxic acute tubular necrosis, most likely due to drugs. So how we can see it under the microscope? These are the tubules lined by epithelium, and we can see that there is undergoing necrosis of the epithelium lining the tubules. So this is acute tubular necrosis. Then goes to if it is diffuse or patchy. In this case, it's patchy. Means here we have normal epithelium lining of the tubule, but here we have a necrosis. So it's a patchy involvement of the tubules, then it's an ischemic causes. Most likely we said heart failure with hypotension. Compared to this picture, they are diffuse, these are all tubules, diffuse involvement of the tubules, and there is vacuolization of the epithelium lining the tubules with dilatation of the tubules. So diffuse process with acute tubular necrosis goes with toxic acute tubular necrosis. Most likely toxic effect due to ethylene glycol poisoning. Another thing called drug-induced interstitial nephritis. What's characteristic here is these eosinophilic cells. These are called eosinophils. If you see an eosinophil in any organ or any picture, this will indicate that there is hypersensitivity reaction is going on. So if you see scattered eosinophil in a picture, this is due to drug-induced interstitial nephritis. You can see along with that mononuclear cells or lymphocytes or even neutrophils also. Slightly drug or classical example is methicillin, but could be seen by other drugs like the thiazide diuretic or H2 blocker. But keep in mind that eosinophils should be there in order to call this is a drug-induced interstitial nephritis. This is grossly a kidney by half into two. What abnormality we can see here is these orangophilic or yellowish deposition can be seen here. This is indicated for a chronic urate nephropathy. Chronic urate nephropathy. Patient will be presenting by what? By hyperuricemia. Hyperuricemia. Because the urate will be excreted in the urine. And sometimes these urate will be plugging the renal tubules. That's why you can see it here. These are all urate or tophus deposit in the medulla. Under the microscope, chronic urate nephropathy will be seen like needle-like shaped crystals. Needle-like shaped crystals in the middle, surrounded by multinucleated giant cells, foreign body type, and mononuclear cells or lymphocyte with or without neutrophils. So again, patient will be presented with hyperuricemia and sometimes nephrolithiasis or uric acid stones. Going to the glomerulus itself. So what abnormality you can see here? This dilatation of the capillary wall of the glomerulus filled with platelet or fibrin thrombi. Platelet or fibrin thrombi. You can see this picture in two conditions. One of them called thrombocytic thrombotic thrombocytopenic purpura. And the other is hemolytic uremic syndrome. You have to differentiate between the two because the cause between the two is different, treatment-wise is different, and even prognosis for both are different. So the same picture is platelet fibrin thrombus inside the glomerular capillary wall. We talk about thrombotic thrombocytopenic purpura. It's due to defect, as you know, in the enzyme of von Willebrand factor. But hemolytic uremic syndrome precipitated by what? A pyrotoxin. That's most likely due to the E. coli coming from uncooked beef or uncooked food. All these two conditions will cause an endothelial injury that eventually will lead to thrombi accumulation inside the capillary wall. So this picture for thrombotic thrombocytopenic purpura, and here for hemolytic uremic syndrome. Again, you can see the thrombus inside or platelet fibrin inside the glomerular capillary wall. As you said, hemolytic uremic syndrome is due to the pyrotoxin from most likely E. coli that's coming from the GI tract due to uncooked or poorly cooked food. Even though the hemolytic uremic syndrome is due to pyrotoxin, but most patients will recover in few weeks with supportive dialysis. So this picture shows a kidney. The normal surface of the kidney should be smooth. But here we have a small granular appearance all over the kidney. So what's causing this? This is due to renal vascular disease called benign nephrosclerosis. Benign nephrosclerosis. What's the cause of this? The small arteries of the kidney will be thickened and narrowed due to the highly atherosclerosis. From where is this highly atherosclerosis? Because the patient is having hypertension or diabetes. So this is a benign nephrosclerosis. We said a benign. So there is a malignant nephrosclerosis. So what's different? Along with the previous picture, the malignant nephrosclerosis will be added to what? Small hemorrhage can be seen all over the cortex and the medulla. If you see a hemorrhage along with that picture previously, so the patient will have essential hypertension or malignant hypertension. That's why it's also called a malignant nephrosclerosis. So under the microscope, what's added is the fibrinoid necrosis. This is the blood vessel wall, and it all goes into lysis or fibrinoid necrosis seen in malignant hypertension. Here we can see a thickening of the arterial wall. Again, can be seen in malignant hypertension. The wall goes into hyperplastic. As you can see, it's like onion skin. Hyperplastic arteriolitis. Characteristic features in diabetic patients is these pink-like hyaline material that you can see inside the glomeruli. These are called nodular glomerulosclerosis. Nodular glomerulosclerosis. This is characteristic for patients with diabetic nephropathy. Along with that, what you can see, the matrix or the mesangial matrix will be expansion or increase, but the hypercellularity of the mesangium would not that much. So plus minus mesangial hypercellularity, but mesangial matrix expansion will be there with nodular glomerulosclerosis. Nodular glomerulosclerosis. How you can see it under the PS special stain, these are the nodular glomerulosclerosis. Along with that, you can see arteriole thickened here. Again, these all picture can be seen in diabetic nephropathy, especially if it is long-standing diabetes. So, a long-standing diabetes mellitus, if the glomeruli has a nodular glomerulosclerosis, eventually the total glomerulus will go into sclerotic. Again, we say mesangial matrix increased, but mesangial hypercellularity or cellularity will not be that much. Now into the new plasm. Here we have the bladder, urinary bladder, open from anteriorly. We can see this growth pattern of a new plasm. And it has a papillary projection or proliferation of a new plasm. Because the lining of the urinary bladder is urothelium, so any carcinoma originating from that will be called urothelial carcinoma. Urothelial carcinoma. The patient will be presenting to you with what? Hematuria. Most classical presentation is by hematuria. Then, after cytological examination of the urine, there could be a shedding from these malignant cells or the surface of the malignant cells into the urine. Then after cytological examination, you will see these malignant cells. But for a definite diagnosis, you have to take a biopsy through cystoscopy to make the diagnosis of urothelial carcinoma. Again, another example of urothelial carcinoma. This is the urinary bladder, and you can see it's filled with a proliferation of a new plasm with papillary-like projection. Most likely, the risk factor for that is smoking, one. Second, what's important of urothelial carcinoma is multifocality. So it will be multifocal. Even if the patient is going into cystectomy or taking out the urinary bladder, the patient have a chance or a risk for a recurrence because it's along with the ureter, maybe the new plasm goes, or even arising from the renal calyx, not only from the urinary bladder. So it's multifocal and has a tendency to reoccur. Here we have the kidney by half into two. Again, we can see the proliferation of papillary new plasm inside the calyx. So this is a urothelial carcinoma. Again, the lining here are urothelium. So any tumor arising from it is urothelial carcinoma. Urothelial carcinoma can be so aggressive as in this picture and can invade the renal parenchyma, the cortex or the medulla, and can occlude the renal calyx system, and then the patient will go into hydronephrosis. So under the microscope, how you can see the urothelial carcinoma? Because it's a urothelium, will have a urothelial lining, but the cells will be pleomorphic. Pleomorphic means increasing in size, hyperchromatic, the thickness of the urothelium is increased, and there is a fibrovascular core in between. Again, higher magnification of urothelial carcinoma, fibrovascular core, the thickness of the urothelium should be 7 layers, but here it's increased. The cells are varying in size, pleomorphic, hyperchromasia, darker than normal, and there is no respect from one cell to the other. So the polarity is lost. All the cells should be perpendicular to the basement membrane, but here we have one cell here and the other are not respecting the other. So this goes into urothelial carcinoma. Again, the same picture. The full thickness of the urothelium is dysplastic. These cells are larger than the others. There is no perpendicular alignment of the cells into the basement membrane. This is the basement membrane. All the cells are hyperchromatic. So all these are affected. It's called a urothelial carcinoma in situ. Why? Because the full thickness is involved and there is no cross of the basement membrane. So only the thickness, the whole thickness is going into a carcinoma or a neoplasm without any invasion into the underlying areas. So this is carcinoma in situ. goes to the kidney, the normal portion of the kidney. Here we have fairly circumscribed mass composed of golden yellow and some area of necrosis or hemorrhage. So this is a mass originating from the kidney. Sometimes if the mass are away from the renal calyx, it could increase in size or even invade other organs before presenting with the patient for any symptoms. So the patient could have free of symptoms even though he is having a renal cell carcinoma. Again, a huge mass is seen here, irregular, non-encapsulated, with some papillary configuration. This is the normal portion of the kidney that you can see it here. This picture is taken from a physician that himself, he didn't have any early symptoms of renal cell carcinoma. Sometimes the patient can be presenting with metastasis rather than from the primary tumor of the kidney. Again, the same gross description of a kidney composed of cystic, mainly cystic, filled with blood. Sometimes we can see simple cysts filled with blood also. But here also we have some necrosis inside the cyst. So, simple cyst can mimic neoplasm or carcinoma or renal cell carcinoma. That's why you have to take multiple sections from the kidney itself to reveal if it is simple cyst or it is a carcinoma itself. A huge mass is seen infiltrating the perinephric fat and even this organ which is above the kidney, the adrenal gland, going into infarct or necrosis due to infiltration of this renal cell carcinoma. The renal cell carcinoma also can go into the renal vein or invade the renal vein. Once it goes to the renal vein, it has a tendency to go into the inferior vena cava and then the heart or the lung or the other area that goes to the other organs. So once it goes to the renal vein, the patient will have a poor prognosis. So the most common carcinoma of the kidney in adults is called clear cell carcinoma. Clear cell carcinoma. From its name, the indication clear cell. Composed of what? Nesting. Here we have one nest. This is a nest. This is another nest. So a nest composed of clear cells, clear cytoplasm, intercellular bridges is prominent, and we have blood vessels intervening in between the nest. So this picture representing a clear cell carcinoma, which is the most common kidney tumor in adults. What about children? What is the most common carcinoma or renal cell carcinoma in children is Wilms tumor. Wilms tumor. This is a classical picture of Wilms tumor, lobulated, tan to white mass, mainly seen in children up to 9 years. And as you know, it's due to a defect in chromosome 11. So the patient or the child will be presenting with abdominal enlargement, and after abdominal examination, you will see that there is a mass effect in the abdomen. So treatment-wise, the survival rate of patients with Wilms tumor is excellent, more than 90% in 5 years. So how you see the Wilms tumor under the microscope? Wilms tumor is called triphasic tumor. Triphasic tumor. That means that there is 3 phases. You have to see it under the microscope to call this as Wilms tumor. One of them is dark blue cells. Sheets of dark blue cells. This is one. Second, spindle cells. Third, these dark blue cells will try to form a primitive glomerulus or primitive tubules, like we can see it here. This is the normal portion of the kidney. Higher magnification, again, sheets of dark blue cells, and they are trying to form a primitive glomerular and tubular structure. This picture typically called Wells tumor. Wells tumor. Any questions? Thank you.